All right, looks like we have some quorum. Would you like to start the bio, Sarah?
Sure. Well, thank you everyone for joining. And for those of you that are joining afterwards and hearing the recording, also thanks for joining. So this is Leith Greenslade. I'm going to give you a brief introduction. She's a passionate advocate for the empowerment of women and children. In addition to her work at Just Action, she leads the Every Breath Counts Coalition, as well as a global health alliance of more than 100 organizations fighting the leading infectious cause of death in the world, pneumonia. She's a proud board member of the Team Fund and an investor of Rice 360 Institute for she's an advisor for Rice 360 Institute for Global Health Technologies and Lancet Foundation. Leith was named Advanced Global Australian of the Year in 2021. She became a Salzburg Global Fellow in 2022 and was awarded the Rice 360 Innovation and Leadership in Global Health Award in 2024. Prior to founding Just Action, she served as a vice chair with the MDG Health Alliance and co-founded an investment circle that supports female social entrepreneurs working globally. She served on the US board of Gavi, the Vaccine Alliance, and in several positions with the Australian government, including the Deputy Prime Minister and the Minister for Health, the leader of federal opposition and the Shadow Minister for Social Security and the Status of Women. She holds a master's in public administration from the Harvard Kennedy School and a master's in business administration from the Chinese University of Hong Kong, and a first-class honors degree from the University of Queensland, Australia. We are so privileged to have her speak tonight, and we can't wait to hear what you have to say. So, Leith, would you like to begin?
Yes, great. So thank you very much. It's great to be here. Anytime Anna Maria asks me to do anything, I say yes. She's a truly wonderful person. So what I'm talking to you tonight about is mobilizing collective action in global health. So I imagine many of you have a sort of a dream in terms of global health engagement. Maybe there's an issue you're passionate about. It's not on the agenda. You don't know how you're ever going to put it on the agenda. This is one of those stories of success. There's a lot of luck involved, but there's also some strategy. So I wanted to share with you the strategy that we were involved in to put medical oxygen on the global health agenda, which it now is. And I think, I hope it sparks other ideas, because many of you, I think, will be able to take the lessons we've learned and apply them to other areas that really need to be global health priorities. So I'm going to speak not for very long, because I hope we can get into a conversation. So I'm going to share my screen. And take you through this. We hope you can see that clearly. So this is lessons from the COVID-19 oxygen crisis, and I'm speaking in my capacity as coordinator of the Every Breath Counts Coalition, which is a large coalition, more than 100 organizations that came together to do this work. So how do you mobilize global health to take on a new challenge, which is effectively what we did? The first question we have to answer is, what is global health? And this is a hotly contested question right now, as I'm sure many of you are aware. There's a huge challenge to really change global health. There's a lot of weaknesses with the model that we've pursued up to date, and it is, it is due for a total transformation. But for the purposes of this story, we were working with traditional global health, which is actually a very small group of institutions. So you have the UN institutions, largely based in Geneva and New York, WHO and UNICEF most relevant for health, but not only, there are others in the family. The big multilaterals, which are now super powerful, the Global Fund and Gavi predominantly. These are our most well-financed global health institutions, very controversially because they've sucked money away from the UN. We can talk about some of the politics of this later. The big development finance institutions like the World Bank, which all of you will know, but every country now as well has its own development finance, or the high-income countries institution. The US has the Development Finance Corporation. You can go around the high-income countries, and they all have these development banks. The traditional donor governments, the bilateral organizations we all know well, USAID, the French one is mentioned there, UK has one, Canada, etc. Donor foundations, Gates looms very large, but there are others. I've listed Rockefeller. The massive international NGOs, which are typically funded by America and a handful of European governments, JPIGO, CHI is the Clinton Health Access Initiative, I'm just naming two. The big research funders, who you'll know well, Wellcome and NIH, and the universities that are powerhouses in global health. Yes, Stanford is one of them, Harvard, and there are a handful of others. These collectively come together to form global health. And if you want to make change, you have to be engaged with all of them. So what's the new challenge we'll be talking about today? Access to medical oxygen. And this is, as clinicians, you will understand the vital importance of medical oxygen. I certainly don't need to tell you about that. But I want to go right back to 2010. It's a long time ago now. But this is when a group of clinicians, actually, you can see them in the paper there, came together to call for global health action on access to medical oxygen. 2010, they published this. And you can read one of the quotes I pulled out from that publication. They were saying there's an alarming gaps in access to medical oxygen. It's causing elevated mortality. We have to do something about it. What do you think happened after that group of academics published that paper? Basically nothing. And we call this the lost decade. Basically from 2009, I think they wrote this piece, published 2010 to 2020 when COVID hit. It was a lost decade. We just couldn't get our act together despite the warnings from academicians and clinicians. So I have to acknowledge a few things did happen, and you'll be aware of this because the safe surgery movement took off over this period. There was a checklist, WHO got behind it. Groups like General Electric, GE was funding, can you imagine? GE was funding some of the programmatic work through their safe surgery initiative. Atul Gawande was working as a surgeon at the time. Now he leads USAID's global health team. He created Lifebox to get pulse oximeters into surgeries all over the world. So the extent to which there was any action happening, it came from the safe surgery movement. So they really laid the groundwork, and we're all very grateful to them, but it was very small movement. We had the Gates Foundation just tiptoeing into the space. They made some very small grants now looking back to INGO's PATH and the Clinton Health Access Initiative to do little bits and pieces of work in certain countries, but nothing major. And then I first got involved really actively in 2016 with the Clinton Global Initiative's first oxygen commitment called United for Oxygen. That's a picture of us on stage with Chelsea Clinton, announcing United for Oxygen, our first attempt to build a collective force for oxygen. We didn't have a lot of money, but we were starting to try and mobilize. So we were beavering away, and then 2020 hit. And I can only describe it as a tragic year. You all have your memories from that year. These are just a subset of thousands of photographs we could have put together on one screen from all over the world, beginning in Latin America in the summer of 2020, moving through Asia and into Africa, into the Middle East. It even went into Eastern Europe. Hospitals ran out of oxygen. We almost saw that happen in some parts of the United States and Europe, but it really happened everywhere else. And these are some of the images of families trying to get oxygen into cylinders, all in cities, towns, all across the global south, basically. Why the cylinders? The hospitals had run out. So these are typically family members standing in line with an empty cylinder waiting to get it filled on the private market to take it back home because dad or mom or auntie or uncle is lying in bed suffocating slowly from COVID, untreated COVID-19. Oxygen was all these families had. They often went home with nothing. many, many, many people died for lack of access to medical oxygen. So a tragic year. What we were doing during that year, Anna Maria will remember well, is screaming at the top of our lungs for action from global health. So during that year, you might recall the Gates Foundation, Global Fund, Gavi, they all started mobilizing around COVAX, putting all of their eggs into the vaccine basket. And great work was done and vital work was done, but nobody was focusing on diagnosis and even less on treatment, which means we didn't have a vaccine recall until December 2020. So all of 2020, we're just watching people die with nothing, no vaccine, no oxygen. So we were screaming for global health to get its act together, but it had no foundation on which to build. So we knew we would have to build it and help them build it, or there would be no action. So let me talk a little bit about what we did to try and get their attention. Remember, this is a very small group, really, of actors meeting regularly in Geneva, London, New York, and of course, Seattle with the Gates Foundation. So we thought, okay, we have a coalition, Every Breath Counts. We had at that time about, 30 members, but we had a lot of oxygen experts in our network because we had been working on pneumonia and respiratory care for many years. We thought, let's bring everyone together. And so we were bringing everyone together in weekly 90-minute calls and growing the coalition as big as quickly as we could to bring all the partners who had the capacity to help on the treatment side together and mobilize them for action. So that's just a little cutout from one of our agendas every week. And what I would do is we would have speakers on our calls. I would do a list of 10 actions that went out 24 hours after the call, really just instructing people, do this, do that, email that person to try and get oxygen and we were doing PPE at one point as well, into the countries where we saw there was the greatest need. So it was kind of 24/7 work, and hats off to our coalition members who really stepped up during this period. So at the same time as we were doing this, we were calling on the ACT Accelerator, that's the word that they use to describe the global COVID response, to mount a serious international emergency oxygen response. And we pounded them all through 2020. So after one of our calls, we would send people off to advocate aggressively, not just with the institutions like the Gates Foundation or Gavi or Global Fund or Wellcome Trust or even the governments. We would be very personal. We were getting people to call leaders on weekends. It was the most aggressive advocacy that I certainly have ever done. And we went well beyond our comfort zone because we just kept seeing the desperation and the tragedy unfold in all these countries, and nobody was able to do anything. We got so desperate towards the end of, well, it was the middle of 2020, we went rogue with the media. So sometimes you'll have to do this when the powers that be don't get the message. So we went to the Bureau of Investigative Journalism and got them to start investigating and publishing in very prominent newspapers that the global health leaders really care about. So the Financial Times, the Guardian, the New York Times, etc., to work with our journalists to uncover just what was really happening. Because believe it or not, the message wasn't getting through to Geneva, New York, London, Seattle. So these pieces, this is just one example, were very, very, I think, influential. But we're still in 2020, desperately trying to get their attention. We realized we needed something a little bit more official than stories of real people. We needed to work with our data, the data that the WHO was getting on the numbers of COVID patients. They published that, remember? Johns Hopkins has a website, but WHO also published estimates, daily, I think, estimates of COVID cases. We took that data and built, with the help of PATH and CHAI, what we called the COVID-19 Oxygen Needs Tracker. This was an online tool. It was updated every day, and it gave you, for every country, every low and middle income country, the amount of oxygen they needed every day just to treat COVID patients. That's the circle on the left. And on the right, we calculated that into the number of cylinders it would take just to treat the patients in that country for COVID every day. So this, and then we pushed this data tool out everywhere we could using social media channels, emails, media, whatever we could, because the quantities were so enormous, nobody could get their heads around them. But this data was all backed out of official WHO data, and we had the sort of the green light from the WHO to present the data in this way. It was a lovely tool, and anybody could have it on their website. We made it freely available to anyone, and we used this data ad nauseum. This came out in November 2020, and we just pummeled the global health decision makers with this data. So, good news. In 2021, things start to look up. In February, the ACT Accelerator group announced exactly what we'd asked for, an oxygen emergency task force sitting within the ACT Day infrastructure right beside COVAX and some of the other things that you'll remember. Wellcome Trust, the wonderful Jeremy Farrar, who led Wellcome, he's now Chief Scientific Officer at WHO, and Unitaid, led by Dr. Philippe Dunaton, ex-MSF, so a medical doctor who truly cares. It does come down to personalities a lot with global health. They came together to co-chair, and that's the announcement that Unitaid made. And it was particularly wonderful for me because that's my birthday, 25th of February. So after all this work in 2020, to have this come on my birthday was like the best present ever. So now we had an official group to work with. And they were represented by UNICEF was on this group, the World Bank was on this group, USAID was on this group. It was all of global health sitting there. We had a group now to mobilize funding and support. So things are looking up. Another piece of luck, which I can't underestimate, is in the Biden administration. We'd been working with a previous administration for 2020, but we had the Biden administration come in the US, and they transferred immediately $3.5 billion to the Global Fund in March to support countries with their COVID needs. And thank you so much. All our advocacy with the US government had worked. They said to the Global Fund, you must include oxygen. So as you'll know, prior to COVID, Global Fund only looked at HIV, AIDS, TB, and malaria. That was their mandate, and they resisted all calls to move into other areas. But with such aggressive advocacy from all of our members, the US government was persuaded to ask the Global Fund, well, require the Global Fund to spend some of that money on oxygen. So now we not only had a body, the ACT Day Emergency Task Force, we had money. That group had money from this large US reservoir to spend and to help countries. So then things started happening there. When you get the architecture right, things start happening very, very quickly. So we started signing MOUs with the big medical liquid oxygen companies, and that money started flowing. So countries apply for that money, and they started getting money for things like PSA plants, oxygen concentrators, masks, all the respiratory ventilators, all the CPAPs, all the stuff you needed for COVID oxygen support. And then you might recall in September, the US hosted the first global COVID summit, when once again we made sure oxygen was front and center. And that's the press release from the Global Fund announcing that $3.5 billion with oxygen. If you scroll down, you'll see oxygen was named there as in scope. We also started, once again, you can't just look at the public sector when you're mobilizing global health. We can't forget the companies. After all, they produce the oxygen, they make all the respiratory therapies. So we then mobilized very quickly to bring industry to the table. We hosted roundtables. We did that in partnership with one of our members, the Access to Medicine Foundation. So we were bringing industry into this new public health architecture that was built to make sure they were talking to each other. I always love creating advocacy tools. We had our COVID tracker, but we needed to be even more dramatic to get to sustain attention. So we created a tool called Oxygen Crisis Risk Maps. We were producing these, I think, every week. Yes, every week. So it was weekly data, and we were highlighting the countries that were about to go into oxygen shortages. So that's the red dots. We had the countries in yellow dots that were very shaky, and the green dots, they were coping, just to give the global health leaders a sort of heads up on where they needed to direct their effort. Unfortunately, the UN and global health is not good at this, at targeting money to where it's most needed. So we wanted to make sure that now that we had mobilized all this money, the countries that were really in crisis, they knew who they were and could find a way to them. I'm not going to go through all the different advocacy instruments that we have used from that time. We're still at it now, just to give you a sense of the massive variety of advocacy communication strategies we pursued. These are all our own sort of created content that we released into the world, or with some kind of connection to oxygen. I can't underestimate the importance of advocacy and communications tools that take academic papers, which frankly, non-academic audiences don't read and they can't read. It's too difficult for a general audience. Even a lot of our global health people won't wade into some of those papers. We have to translate them into simple, captivating, dramatic information to have all that great academic work translated into action. So there's just a few of the things that we were up to. And so what happened over 2021 and 2022 and 2023, more than $1 billion came through the Oxygen Emergency Task Force to over 100 countries, more than $1 billion from February 2021 to the end of 2023. Most of that came through the Global Fund, but not only. A lot from WHO and UNICEF, a lot from UNITAID and other donors, Elmer Philanthropy, Skoll Foundation, USAID. You know, we were trying to get as many donors into the mix as possible. I've listed some of that there. We also saw some new initiatives bubble up. So it wasn't just the traditional players. When you have this much activity in a neglected area of global health, you get a lot of new ideas, which is great. So the Oxygen Hub, the Oxygen Alliance, Oxygen Collab, you can Google all of these. They all have an internet presence. They're totally new things that didn't exist pre-COVID. We were able to make some revisions to some policy documents that were out of date. The WHO Pharmacopoeia, which stipulates oxygen purity. They only had oxygen 99.5%, which is the liquid oxygen used in the US and Europe, but not available to most African countries and large parts of Asia and Latin America, where they rely on PSA plants or concentrators. We had to change that document and encourage national governments to change theirs as well. So PSA plants and little concentrators could be used without any sorts of legal challenges. And then we had the second US Global COVID Summit. I think that was 2022. Once again, oxygen, we managed to keep oxygen on the list. And then we just wanted to highlight there one of our advocacy efforts with biomedical engineers. So through all of this, we were very conscious that global health is largely a European and North American entity. And as I said at the outset, there's big moves to change that. Every step of the way, we've tried to lift voices from Africa, Asia, and Latin America. This is just one of our efforts, lifting biomedical engineers and technicians. We have more than 120. This is Jonas from Rwanda. We have more than 120 like Jonas, 50% are women. We're super proud of that. And every week or so, we were raising their profiles in an effort to get global health to listen to voices like that, the biomeds who keep all the equipment working, who are often neglected after the clinicians. I have to call this out. There was so much training of clinicians and biomeds online during COVID for obvious reasons, but the efforts of Anna Maria and the partners that came together for the Oxygen series, just above and beyond. I don't know how you can ever capture how many lives were saved with these kinds of tools, but it's a lot, because we heard from the clinicians who told us that they had learned how to use a pulse oximeter or had had a particular question about a CPAP answered because of these online trainings, or they'd felt the confidence to use a technology that they might not have had the confidence to even attempt. So I just want to give a big shout out to the whole team who pulled this series together. I don't know, I hope people haven't forgotten the heroic efforts like these and just how many lives were saved. I fear that we have, but we must always remind everyone of this kind of effort, because we're going to need to do it again. We're going to have another pandemic, and it probably will be respiratory at scale, and we're going to need to dust these things off and keep going with them. This is just a little map showing you the scale of the, I talked about 100 billion before. through the ACT-A Oxygen Emergency Task Force. This is where it went, some of the countries it went to, and some of the NGOs that took that money. Of course, a lot of it went directly to ministries of health through Global Fund, but the ones that came through international actors, these are the international actors. So Africa benefited enormously from the international effort, but also other parts of the world. And just keep in mind, all of this was mobilized and delivered in 12 to 18 months. A massive effort for global health is very slow, but so a massive effort, even though we say it could have been faster, it was fast. Okay, not content to just leave it at that, we thought we have to come to terms with what has just happened, because global health was blindsided. National governments were blindsided. Too many people died because of COVID, and we weren't ready. How do we get a handle on what just happened so that it doesn't happen again? So we approached Lancet Global Health. Zoe Mullen is our editor, to say, would you take on a commission on oxygen? We had to persuade them. They've only done a few commissions, Lancet Global Health. I believe this is only the 4th, but she was persuaded and they took it on. So we've also been, in the last 2 years, this was announced in 2022, conducting a commission, which we've just submitted, and it will report in 2025, early 2025. It has a lot of recommendations for how to keep going with what we're doing, but do more to make sure we're ready next time. So some of the other challenges that we still have, because global health is a very fickle beast. When funding dries up, it can move on to other things. We have to keep them at the table. So in addition to the Lancet, which is one of the tools to keep them at the table, we were very successful in encouraging the ACT Accelerator Oxygen Emergency Task Force to continue and not wind up. Now, COVAX wound up, but we said, no, why don't you morph into a global oxygen alliance and we'll continue our good work. And they did that. But this time we have Global Fund, hugely important. Global Fund co-chairing with UNITAID, and we persuaded them to bring regional co-chairs in Africa CDC and PAHO for Latin America. So we don't just have these voices, European and US voices, dominating all the time. So the Global Oxygen Alliance is now working and functioning. And they're about to launch another call for more funding, this time 4 billion. I think I can tell you that. It's not announced yet. They're about to launch 4 billion for more funding to continue the work. We were able to work with the WHO to have an oxygen resolution. That was May 2023. So the WHO now has a tool to keep it in the game. It lasts until 2030, and all member states unanimously endorsed that resolution. So what you can see, we're trying to find ways to keep everyone at the table. And there's a World Oxygen Day now, October the 2nd every year. This is only the 2nd year it's happening. So now we have a Global Advocacy Day. Some people think there's too many of those, and there probably are, but now we have one too. So we're still continuing our challenge of embedding oxygen in global health. I'm not going to go through all those in detail, but these are all the different areas that we're continuing to cover to keep oxygen front and center. So this is not a one and done. Unfortunately, when you get something on the global health agenda, you have to fight to keep it there. And that usually involves money and advocacy and more data, and so it goes. So we're still in the game. We're still doing this. That's our ultimate vision for how the system would all work together like a set of gears. Our governments have to be at the center, not global health. And then we surround sound the governments with all these different, that's just a summary of all the different things I've just talked about, how they fit together to keep the pressure on the governments to do what they should be doing, but many can't. That's the advocacy tools we have. This is not expensive, by the way, in terms of mounting an advocacy effort like this. All we really had were websites, YouTube channel, X accounts, LinkedIn accounts. We use Zoom to meet regularly and send the newsletter. So the actual overhead of mounting a campaign like this is not expensive. It's just time intensive. And it requires a kind of attitude that is the opposite of 9 to 5. You really have to have people who want to get up on Sunday and they just have to get back at it. Not everyone has appetite for that, but that's the way to be successful at this kind of enterprise. So you might ask, why is this lady we've been looking at for this entire presentation still unhappy? It's because there are massive gaps remaining in oxygen access. I can't give you all the details of the Lancet Global Health Commission until it's published, but I can tell you that the gaps we've uncovered, even with all the support I've just described, are enormous. We're putting a number on that for the first time. And it's overwhelmingly large, and it would cost many, many, many billions of dollars. So we'll start off 2025 by putting that out into the public arena and hopefully keeping people once again at the task of mobilizing more resources for this. We'll stay at this until at least the SDG sunset, 2030. That's just around the corner. Oxygen is integral to the achievement of most of the health SDGs. So we'll keep working. That's our time horizon. And of course, my final point, and then we can wrap up. We have estimates that another respiratory pandemic is 66% likely in our lifetimes. And that particular pandemic would kill at least 10 million or more. These are estimates from Ginkgo Bioworks. So we know we're going to this is going to happen again. It's not if, but when. And it would be absolutely unforgivable if we entered the next one the same way we entered COVID, and if we came out of it with tens of millions of deaths. So that's our North Star. That's what we have to prevent. In the meantime, the beauty with oxygen is it's going to save lives every day, because neonates, women in childbirth, people with chronic and infectious diseases, people needing safe surgery, all of these patient populations need oxygen. So it's doing double duty. It's saving lives now and preparing us for the next pandemic. Thank you so much for the opportunity to share the story with you.
Leith, thank you so much. Again, I'm just absolutely thrilled that you have agreed to spend your time with us tonight. And I just want to kind of paint the picture for the audience, just how incredibly fearless and effective you were during this time. Those Every Breath Counts calls really did bring together lots of different organizations who normally maybe wouldn't work together, but you know that your critical actions at the end of each of those really were incredibly effective at mobilizing people to work together and to collaborate during this really critical time of the pandemic. And I just have admired you ever since, watching you navigate, hundreds of people on a call, and just the relentless advocacy that you continue to push through, and the way you mobilize really huge players across the globe is just remarkable. So just a huge, sincere thank you for all of the work that you do, and it's incredibly inspiring. And yeah, you're tenacious, and you persevere through a lot, and never lose sight of what needs to be done, and are not afraid to call people out when they're not holding up their end of the bargain. So just a huge thank you to you for all of that work during the pandemic. I have a million questions, but I'd love to open it up to others, because I would definitely consume all of the time you'd give me. But so I would love to hear from others. We have a lot of really great people on this call. The director of our Center for Innovation and Global Health, a lot of great colleagues in the anesthesia department, colleagues from across the globe that were also part of the oxygen and critical care training that we did during the pandemic are on the call as well. So would love to hear and have some engagement from Dr. Dati, Dr. Rodrigo Rubio, Michelle Berry, lots of people that could comment on their perspectives.
I had a question.
Can I say something?
Go ahead. Yes.
Oh, thank you. This is Dr. Dati from Nigeria. I'm happy I've not missed this lecture. I've learned a lot, and it can only inspire me more to be involved in this oxygen training. Like I shared on the chat box, I worked with Anna on during the COVID-19, this basic, emergency and basic oxygen therapy, which kind of prepared me for another training that just came my way and right in my rural state. And it's not, first there was no oxygen. Now, because of COVID-19, we have plants either constructed or being constructed in all the 36 states of Nigeria, including the federal capital. And some hospitals are also using liquid oxygen at the moment. But what I found out is that it's okay to have the oxygen, but it's another thing to administer it correctly. And that's what I found out during the training that was funded by Save the Children Inspiring Project. We did 3 trainings, and when I came back to my hospital, the tertiary hospital, we found out that those we train in those rural areas, these are observations, we are better at administering oxygen. So that led to the formation of a committee. There's a standing committee in the hospital now, Aminu Kano Teaching Hospital, that oversees regular training for all the healthcare professionals on how to give oxygen. And they are all happy about it. So the point I'm making is that training is key. Once we get the oxygen, then we should key in the training, which is very, very simple. And they found out that many patients, even yesterday, somebody called me from one of the hospitals to thank me and my colleagues for teaching them. They have oxygen. They are constructing another plant in that hospital. And they found out that patients were getting better, because they now know how to give oxygen. Thank you.
I'm so happy to hear from Nigeria. There's, in terms of the priority countries for oxygen support, Nigeria was number 1 because of the size of the country and the gap. So it's wonderful to hear that the oxygen is coming in, the PSA plants and others are coming in. And in fact, your wonderful health minister, federal health minister, Dr. Mohammed Pate, just signed a big partnership with a big liquid company called Global Gases to bring even more liquid oxygen into the health system in Nigeria. So it feels like Nigeria is really moving ahead, but your point on the training is really well taken. So one of the weaknesses of the global response was a lot of equipment was purchased and sent. So PSA plants, concentrators, you name it. They spent most of their money on the equipment and hardly any money actually on training. So they're trying to fix that now. So with this new 4 billion I mentioned, the 4 billion they're going to ask for, the lion's share of that is going to be for training, not just clinicians, but also biomedical engineers and technicians, because to your point, they realize they made a bit of a mistake in not providing enough funding for training.
Yeah, great. Thank you.
I often see, and I think that's one of my bigger criticisms in global health in general is there's often great policy changes that may even trickle down to a Ministry of Health or even a hospital's director general. But then there's this gap between those policies and the bedside that seems sometimes insurmountable. And I think it's often overlooked, that last step to get to the patient. So I think that's great to hear that the training is also being prioritized. I think for the audience, it's important to recognize that this is not just a low and middle income country problem. LA ran out of oxygen, if you recall, during the pandemic. And also I think for a lot of us, I mean, we use oxygen every day in the operating theaters, and the ICU units, and during patient transport, and out of OR anesthesia as well. And I think one of the things that I find challenging with the topics that I am passionate about, oxygen being one of them, is keeping that momentum and keeping it on the priority list, because that priority list, especially in this day and age with short attention spans, changes so rapidly. I'm wondering if Leith, you've seen any collaboration to bolster oxygen with the ECO resolution, which was the vowing of member states to strengthen health systems, emergency, critical, and operative care, that came out in 2023. And then this year at the World Health Assembly, they said, oh yes, we need to implement this now. And so it was great to actually get critical care on the priority list. But it seems to be easily replaced by the other topics that people have decided to prioritize. Some of them, of course, equally as important, but I feel like if we don't strengthen the health systems with the essentials, the essential critical care, the essential oxygen, essential medicines that the patients actually need, and we focus more on, you know, specific disease states, or, you know, oncology and cancer has become very high on the priority list lately, we're going to continue to see the same amount of morbidity and mortality because the system is simply not ready to take care of the patients, regardless of what the policies say. Do you have thoughts about that? Advice for those of us in academic medicine who are trying to also be advocates for our patients, of how to find those synergies across different issues and advocacy?
Oh boy. So global health does not have a great way of determining priorities. You would think that they would look at the global burden of disease and figure out where the risk, who's dying of what, where, early deaths, preventable deaths, and mobilize around a set of priorities that would save the most lives, and interventions that would save the most lives, but they don't. So you have all of the money really sitting in Global Fund and Gavi, let's say. So the multilaterals have done, those agencies have done extremely well at capturing the lion's share of global health money. Donors like them. Donors like Global Fund and Gavi. And then you have UN agencies like WHO, which you would think would be the one that would establish the priorities, the overarching health priorities, with no money. I mean, I can't tell you how dire the funding situation for WHO is. So if you are going to try and persuade WHO to take on emergency critical care, you'll have a conversation with them. They'll probably be welcoming. You may even get a policy change, but it will mean nothing on the ground because they have no funding. All the funding is locked in for HIV, AIDS, TB, malaria, vaccination with Gavi, and ministries of health on the ground respond to where the money comes from. We can debate this, we can talk about this. It's not a pretty picture. This is the way it is. So you'll be struggling all the while you don't have significant financial resources behind your agenda. The only reason our oxygen story looks like a great success, but the only reason it really was that 3.5 billion transferred from the Biden administration to Global Fund with oxygen in scope. That changed everything. Money changes everything when you're trying to have a major change. So if you're looking for hospitals all across Africa, Asia, Latin America, whoever has massive critical care gaps, to totally transform their critical care services, you're going to need funding to help most of them do that. Not all of them, but most of them. The budget situation, the health budgets of most low and middle income countries, particularly Africa, is really, really bad after COVID, with debt and the rest of it. It's a bad situation. So to ask them to do specific things that are new will require new money or shifting money around from other areas. So we never like to talk about this in global health, the reality of how it all works. I mean, there's been efforts from time to time to have the Global Fund broaden its mandate. So it's not just working on 3 infectious diseases, but it's able to work with country priorities like critical care and other things. But we're just not there yet. It doesn't mean you should stop working with WHO. It just means you need to be realistic about what can be achieved. Some of the exciting things that have happened, to be more positive, is African health institutions have really started to get stronger after COVID. The Africans are furious with the way they were left high and dry by global health. And so not surprisingly, the Africa CDC, the African Union, the African medicines, there's a raft of them. They're building their own institutions to try and wean themselves off unreliable global health support. You may do better to go and engage directly with those institutions if you have a change agenda than trying to come at it by going through a UN agency or a big group like USAID. This is what I mean by global health is in flux and changing. I know there are other people on this call with expertise here and they would have views on that as well.
I had a quick question to kind of add to this conversation. You talked about, that there is such a large gap still and that 4 billion is still required. A lot of that is going to go into training. Do you think the reason that these gaps remain, is there anything to do with corruption? Is it just that the estimates were low and that a lot more resources are needed? Like with that money transfer, is corruption a concern, or what has your experience been with that? And how are you involved, I guess?
Yeah, so we do track I mean, it's $1 billion worth of equipment to over 100 countries is a big shipment of equipment. But given that most of it or a lion's share is through the Global Fund, and they have very careful, I mean, these are very sophisticated agencies now, Gabby, too, for tracking things and protecting, it's all donor funded, so protecting the equipment. And if there is any corruption, they have whistleblower programs and all sorts of ways of tracking that and correcting that. And they do sometimes, where they find corruption, they do act. They turn off the supply of money until it's all cleared up, and governments have sometimes had to pay things back. So when we haven't come across any massive corruption, the biggest issues we've come across are really beautiful new machines arriving with no one on the ground to operate them or understand how to operate them, which is no fault of that's on global health for being so silly. So yeah, not so much corruption, but the wide gaps that exist at the moment are because national ministries of health just simply haven't had oxygen on their agendas. It hasn't been something they've provided. And that's changed now. COVID put it on the agenda for all of them. So they're scrambling to catch up. But and someone's put a comment about waste in the chat. Yeah, you can walk into a hospital in the States or Europe and the oxygen is just wasted. It's just considered, it's always there. You just turn it on, it comes, and it's not so much a precious resource. So there is a lot of wastage. It's the opposite is the case in many of the places where our members work, where it's just not available. There's no concentrator and there's no electricity anyway, so it wouldn't work. There's certainly no PSA plant on site. And the nearest liquid oxygen factory might be where the mining company, is based, hundreds of miles away. And that oxygen is produced for mining or heavy industry, not for the health system. So this is still the reality in many, many places.
Farai Matsumbamuto, who's one of our colleagues, we used to have a partnership in Zimbabwe. He's now in Botswana, wrote a really lovely article, I don't know if you recall, called "Ventilators Are Not the Answer" in Africa during the pandemic, because a lot of high income, high resource settings started to just flood places with ventilators. And he scolded all of us because a lot of these places didn't have oxygen and they didn't have electricity to run the ventilators, nor do they have the trained personnel, much to Dr. Dotti's comment. placing someone on a ventilator is really just the start, and they can actually become weapons more so than helpful, because the patients end up getting complications and ventilator associated pneumonia and septic shock, and they die. So having a ventilator in and of itself was really problematic. And I think his greater point was that if we could actually take the time to understand the problems between the policy, the equipment, and the workforce, and how to actually make it work at the bedside where the patients are, why we're all doing this, we really could have a much, much greater impact overall. The money that we spent, corruption is certainly one thing, but a lot of it is wasted, wasted on the wrong things. There's also, a lot of concern with big projects about the phantom aid. So much money is spent on running the programs that the impact is actually diluted out, and the money is poorly spent.
Yeah, all of that is so true. We actually had the phantom aid, forget his name now, but we had him on one of our calls during COVID, just issuing that kind of warning. Yeah, so one of the good things about WHO and the oxygen resolution is every country signed up to having a national oxygen plan. What that means is that the countries will say, they'll have to examine their own health systems and say, this is where our gaps are, this is what we need, and they'll be pulling it into the country rather than having global health push it in. So this should reduce the risk that they receive equipment they don't need or they can't use. WHO is doing, I think, a nice job with these. They're called national oxygen roadmaps. Several of the countries already have them, but it really should be the government that determines this is what kind of system we want for oxygen, this is what we need, and then the outside help comes rather than the other way around.
Mike Hess, hello, is on the call. He says corruption may be a concern, but I'd wager the bigger issue is that public health and chronic non-communicable disease management doesn't have a flashy deliverable. It takes years to demonstrate changes and outcomes. So people kind of lose the motivation, which I agree with. I think even oxygen is somewhat easier because it's one thing. It's an essential medication. It seems so obvious that everyone should have oxygen, but when you start to talk about health systems or creating systems that work better and more efficiently, it becomes a little messier, even if it's just perioperative care or critical care across the system. There's so many moving parts, stakeholders, and nuances to each actual location that it really is quite challenging to get a lot of change coming from the outside in.
Can I raise a point? I just wanted to give a shout out to clinicians. So during COVID, some of the best results we got in terms of action were when a local clinician or a group of clinicians decided to go right out on a limb and start advocating on behalf of their patients. And in many of these settings, they do so at great risk because you're not supposed to be critical. The government doesn't like you to be critical of the health system. But we would not have been able to do what we did without some very brave clinicians, and many of them were critical care clinicians working in appalling conditions. But they just decided they were going to speak out and say, this is what we need. This is what my patients are going through. This is how many patients I lost last night because I couldn't steal an oxygen cylinder from another part of the hospital. And I tried, but I failed, and then they died. So they told us these stories and they gave us permission to share them. So I just want to, I guess, with your audience here, don't ever underestimate the power of a brave clinician because we certainly depended on them.
I think that's, and please everyone jump in because again, I already warned you I would dominate the time with Leith if I could. I think it's an excellent point, and I would love to hear your thoughts, Leith, about when you're in a room with someone trying to convince them of your passionate plea and advocacy for an issue, it's sometimes a little bit difficult to decide, am I going to use the data or am I going to use the story? And a lot of times it is that heartstring that needs to be pulled, or those very compelling stories. How do you decide when you're in a room which tactic you're going to employ?
So we know it's know your audience, because your audience and really know them. So we did such personalized advocacy. We knew exactly what might move these key decision makers. So the head of the Global Fund, Peter Sands, very influential guy, banker, ex-banker. We knew what sort of things motivated him and moved him, and we needed him because we needed the Global Fund to be active in oxygen. And they historically had not touched anything beyond the 3 infectious diseases. So we knew we had to get to him. So we knew he read the Financial Times. He's a banker. We knew that. So we had a story placed there which appealed to him and referenced him. And in a kind of way, I'm giving away all our secrets on this call. We shamed him. He's a lot of these guys that run these big global health agencies, they have a lot of pride and they're interested in their legacy and they don't like bad news. So we worked with everyone's weaknesses as well as their strengths. And so sometimes we would go with data, but we did use a lot of personal stories and we used a lot of patients in their own voice. And we don't do that enough. Actually, we don't do that enough. As you said before, there's a deep disconnect between global health decision makers and patients and their families. And we needed to break that down and connect the two directly, because really that is who these people are supposed to be accountable to. We're supposed to be accountable to the users of health products, the people who are sick and their families who have to deal with that and deal with the repercussions of that. So I can't emphasize that enough with advocacy communications. Break down the barriers between patients and their families and whoever has to make the decision, because they often don't like to be confronted with those stories. They find them really difficult to deal with.
One of the lines out of the Lancet Global Health Commission on quality of care, health systems quality of care, says something to the effect of health systems or governments will know when their health system is adequate when the leaders of the government choose not to leave the country to seek care. And I think that's actually incredibly compelling.
That's the point. Yeah, that's the point. Yeah.
Be a good place to wrap up our lecture tonight. Does anyone have any other questions or comments? Leith and Anna, that was a wonderful conversation. It was like a fireside chat. And honestly, I don't know if anyone else had this feeling. It was like this deja vu moment to kind of, I saw Anna and our other faculty be involved in these efforts with you. I remember those calls and being so impressed with you, Leith, you're like, UNICEF, you're going to do this. This person, like I remember hearing a story from Paraguay, which is where my mom is from, and didn't hear anything about that in the news. So it's really, you really stuck with me, I think, as like a beacon of hope during this really tragic and depressing time, I think isolating for many of us. So it's really cool to hear the successes. And I think that there's still so much more work to be done that we can also contribute to. So thank you.
My pleasure. Thank you for the invitation.
Leith, I'm over the moon. Thank you so much for spending time with us. It's such a great honor and a privilege to have you. And again, cannot stress enough how important you are for the world. So thank you for everything that you do. Really grateful to you and all the work.
Well, let's keep going. Let's keep climbing mountains. Thank you.
All right. Thanks, everybody. Thank you.
Thanks so much
Thank
for joining.
Thank you.